Kia ora, welcome everyone. My name's Sally from Leukaemia and Blood Cancer New Zealand. Welcome to this session on MPN updates with Dr Humphrey Pullon. Before I introduce Dr Pullon, just a reminder that there is a Q&A button along the bottom of your screen. So you might just need to hover your mouse for it to appear, but you can click on that, type your questions, and if we've got time, I'll read these questions and get Dr Pullon to answer them. So it's now my pleasure to introduce Dr Humphrey Pullon, who is the Consultant Haematologist based in Hamilton. After training in Auckland and at King's College in London, he returned to the Waikato Hospital, where he has been since the early 1990s. Humphrey also works from PathLab in Hamilton and has a role as a clinical advisor to the New Zealand Cancer Agency, Te Kahu. Humphrey has a strong interest in malignant haematology and has developed the Autologous Stem Cell transplant program at Waikato Hospital. Besides his interest in leukemia, lymphoma, and bone marrow failure syndromes, he also has an interest in chronic myeloid leukemia and is a co-investigator on the KISS CML clinical trial. He has quite a number of patients with myeloproliferative disorders and has an increasing awareness of the role of molecular testing, particularly for patients with myelofibrosis. So it is my great pleasure to introduce and hand over to Dr. Humphrey Pullon. Thank you. Over to you, Humphrey.
Okay. Can you see that, Sally?
Yes, I can. That's working really well.
Well, kia ora and welcome everybody to this session on myeloproliferative disorders. It's a pity we can't be in Christchurch, but having said that, we are certainly thinking of the folks in Auckland, and many of us have family and friends there who are doing it a bit tougher than the rest of us. So first of all, what is a myeloproliferative disorder? Well, they are a group of conditions really characterized by overgrowth or clonal proliferation of one or other of the blood cells in the bone marrow. And in some cases, they're associated with enlargement of the liver and spleen. And the three major myeloproliferative disorders are listed on the slide there: polycythemia rubra vera, essential thrombocythemia, and myelofibrosis. So polycythemia rubra vera is associated with proliferation or overproduction of red blood cells. Essential thrombocythemia associated with overproduction of platelets that come from megakaryocytes in the bone marrow. And myelofibrosis is where there is excess scar tissue laid down within the bone marrow space. There are a number of rarer myeloproliferative disorders that are associated with overproduction of mast cells and eosinophils, but they are much less common. So the important thing about myeloproliferative disorders is that the switch, if you like, the mutation that occurs in the earliest blood stem cell within the bone marrow. So on the left in the picture there. And you can see that once that switch is flicked, that drives an overproduction of blood cell progenitors within the bone marrow. So the bone marrow goes into overdrive. And I often say to patients, what you've developed is an overdrive problem in the bone marrow or in the blood factory. So when we do a bone marrow test, we see lots and lots of blood cells being produced. And this is a picture of somebody's bone marrow with a myeloproliferative neoplasm, where you can see the various black dots are all red blood cell precursors and increased in number. Then there are a whole lot of fried eggs with little round black circles with little dots in the middle of them. And they are all neutrophil or white blood cell precursors. And then there is a big fried egg right in the middle of the picture, and that's a megakaryocyte, and that's producing platelets. So when we look at a bone marrow of somebody with a myeloproliferative neoplasm, we see a bone marrow, a blood factory that's very busy, that is working far more actively than it should, and in that sense is working in overdrive. So just moving on to how myeloproliferative disorders can affect you. Well, the first thing to say is they can be asymptomatic, and a number of people are diagnosed with their myeloproliferative neoplasm just because they happen to have a blood test with their GP. And if that's the case and it's not affecting you at the start, then that's a very good thing and makes, in some ways, treatment more simple. But having said that, there are another group of patients who do present with significant symptoms. And I've listed those on the slide. If people have too many red blood cells in their system, they often present with headache and blurred vision. So they're quite common symptoms for people that have polycythemia vera. Fatigue, weakness, and dizziness, again, we see with a number of myeloproliferative neoplasms. Itchiness is a particular problem, and we'll come back to that towards the end of the talk. Occasionally, in people with myelofibrosis, we find people develop night sweats, particularly drenching sweats at night, and they tend to lose weight. If people have a big spleen in their left upper quadrant, which is what LUQ stands for, so the left upper side of their tummy, there, that is where the spleen lives, and if it's enlarged, it can cause pain in that area. And sometimes you can get high blood pressure, and sometimes myeloproliferative neoplasms can cause gout. So there are quite a range of symptoms that can sometimes be a marker that all is not well in the blood factory. But perhaps the more serious complication of myeloproliferative neoplasms is that of blood clots, or what we call thrombosis. And thrombosis that occurs in the arteries around the brain can cause stroke. And if it's affecting the coronary arteries around the heart, it can cause heart attack. And people can also get clots in the veins of their legs and get deep vein thrombosis. So if those things occur, then treatment for the myeloproliferative neoplasm, pardon me, is very, very urgent. And sometimes poor circulation to the legs can also be an issue. Pardon me, I'll just have a mouthful. So if clots occur, we need to treat urgently, and certainly much of the treatment for myeloproliferative neoplasms is designed to prevent people running into problems with clots. Well, what about diagnosis? And when I thought I was presenting to a Canterbury audience predominantly, or a South Island audience, I thought they'd identify with this picture of a brown trout, obviously. And that's a jack or a male brown trout. And we can tell that because of the hook on the jaw at the front there. But the importance of mentioning male brown trout is because of JAK2. And in terms of myeloproliferative neoplasms, what we're particularly thinking about is the JAK2 mutation. So the JAK2 mutation that you can see midway down the slide there where it says genetic testing, the JAK2 mutation is one of the tests that we do to make a diagnosis of myeloproliferative neoplasm. And as it says there, in 95% of people with polycythemia vera, 50% of people with essential thrombocythemia, and about 55% of people with myelofibrosis, the JAK2 mutation test comes up positive. But having said that, before we get to genetic testing, we always look at the blood test, and the blood test often will give us a major clue to the diagnosis. So if people are developing polycythemia vera, we're particularly looking at a high hemoglobin and a high hematocrit level. If they're developing essential thrombocythemia, they typically have a high platelet count. And if people are developing myelofibrosis, we often see immature white blood cell precursors in the bloodstream circulating, whereas they normally live within the bone marrow. So the blood test results do give us a major clue, and genetic testing is also important, and I've mentioned the JAK2 mutation. If people have a myeloproliferative disorder, but they happen to be negative for the JAK2 mutation test, then we go on and test for two other mutations, what's called CALR, or the calreticulin mutation, and the MPL, which relates to the receptor on megakaryocytes for thrombopoietin that drives megakaryocyte production of platelets. So some people, particularly those with essential thrombocythemia, are positive for the CALR mutation or the MPL mutation, whilst being negative for JAK2. In addition, we often end up doing a bone marrow test, and that's particularly so for people with myelofibrosis. And if we're worried that people may have a diagnosis of myelofibrosis, looking at the bone marrow and particularly looking for evidence of increased fibrosis and other abnormalities really does confirm that diagnosis. So those are the major sort of diagnostic things that we do to try and make a diagnosis of a myeloproliferative neoplasm, and in particular, make sure we're dealing with the right group of MPN, because to some extent that does dominate treatment. So what about treatment of myeloproliferative neoplasms? Well, the first thing to say is that aspirin is a very, very good drug for the vast majority of people with myeloproliferative neoplasms. So we typically use low-dose aspirin, and low-dose aspirin has what we call an antiplatelet effect. So it affects the function of the platelets, the blood clotting cells, and I often say to patients, it makes the platelets less sticky. So even if they have a high platelet count, by making the platelets less sticky, it does reduce the risk of clots. It reduces the risk of those platelets sludging up and causing trouble. So low-dose aspirin, very important. It's also very important in people with polycythemia vera, as we'll come to one of the complications that people with P vera can get, which is particularly improved with low-dose aspirin. So low-dose aspirin to reduce the risk of clots and thrombosis, very important. Venesection, or bloodletting, or phlebotomy as we call it, is where we take excess blood out of a person's body. So this is done for people with polycythemia vera, where they have too many red blood cells, and as a result of their hemoglobin level being very high, their blood is very thick and sludgy, and it's very important that we reduce the blood viscosity by venesecting and taking away the excess red cells. So venesection, very good for acute treatment and for the treatment of younger patients. And I will go on in subsequent slides and talk about the other treatments as listed on the slide. So just to show you a picture of what happens when somebody gets venesected. So they go into a phlebotomy nurse, has a tourniquet put around their arm to bring their veins up and make their veins enlarged. And then quite a large needle, what we call an 18-gauge needle, is put into a large vein in the arm, and then the blood is run out through the tubing into a bag like that. So that's exactly the same procedure that a blood donor undertakes when a blood donor goes in to donate blood. So we typically take off about 450 mils of blood each time when a person has a venesection. And although that person is sitting up and having their venesection, in general, it's a good idea to lie down after a venesection or during the venesection, because it does take a while to your body to adjust to being without that 450 mils of blood. So we ask people to drink plenty. We ask people to lie down for at least 5 minutes after the venesection is completed, and always get people up slowly so that they don't get into trouble with lightheadedness, dizziness, or worst case scenario, fainting. So venesection or phlebotomy, very effective way of getting rid of excess red blood cells, and very, very good thing to do acutely, particularly if somebody presents with a clot because their blood has become very viscous and thick and sludgy. So what about hydroxyurea? So hydroxyurea is probably a capsule that many of you are familiar with, this pink and green capsule that is used widely to treat people with myeloproliferative neoplasms, and in particular people with polycythemia vera and essential thrombocythemia. So Hydroxyurea, or hydroxycarbamide is the other name for it, is very well tolerated by most people. A simple tablet or tablets that people take on a daily basis, usually. And the side effects are fairly minimal, but occasionally people are troubled by nausea. And very occasionally, hydroxyurea can cause leg ulceration, particularly ulceration just above the ankle, or ulceration sometimes of the toes. And very occasionally, it can upset how your liver works and cause liver dysfunction. So it is a drug we have to use cautiously and carefully. Yeah, I mean, we start at a low dose and make sure the person's tolerating it first, and then slowly increase the dose to try and get good control of either the hematocrit if we're treating polycythemia vera, or the platelet count if we're treating somebody with essential thrombocythemia. One thing that's quite important about hydroxyurea is it can affect your skin, and it particularly can affect the skin if you've been a Caucasian farmer and you've been outdoors much of your life and had some sun damage from many years exposure in the sun, and then you start treatment with hydroxyurea, it can really cause trouble with your skin. So I certainly advise Caucasian people, and particularly in the Waikato Caucasian farmers, as soon as we're starting them on hydroxyurea, to make sure they get a skin check and make sure they're being reviewed regularly, because sometimes hydroxyurea can make skin problems, and in particular sun damaged skin and solar keratosis and even precancerous skin lesions worse. And we do have to be careful about using hydroxyurea in that context. In terms of how much hydroxyurea, well, the capsules come in 500 milligrams, so one capsule is 500 milligrams, and usually we will start off at just one capsule a day, but we often increase the dose further up to 2 capsules daily in some people, and a pretty much maximal dose is 3 capsules a day. So we're always increasing the dose gradually, and always looking at the response, making sure we don't overdo it with this hydroxyurea treatment. And in terms of what response are we looking for? Well, we are looking for a hematocrit in polycythemia, getting the hematocrit down to 0.45, and in people with essential thrombocythemia, trying to get the platelet count down to 400, which is the upper limit of normal. We don't always manage that with essential thrombocythemia, but we certainly like the platelet count under 600 by 10 to the 9 per liter. So adjusting the dose to try and get the hematocrit down to target in polycythemia is very, very important. There are some people, and particularly people trained in the US, that believe if you're a woman, then the target hematocrit should be 0.42. But I must say that that's not universally accepted worldwide. But if people have a history of clots and have had thrombosis somewhere, then sometimes we do bring the hematocrit even lower than 0.45. But 0.45 is the standard target for most people. One of the queries about hydroxyurea is, does it make my myeloproliferative neoplasm worse? And people often worry about the fact that because it is a gentle form of chemotherapy, does it increase my risk of my myeloproliferative neoplasm changing into acute leukemia? And I have to say, and I can pretty much put hand on heart, that studies that have been done to look at that have not shown an increased incidence of people getting leukemia from hydroxyurea or hydroxycarbamide. So I think we're pretty safe in continuing to use this drug fairly widely, and it is a very effective drug for most people in that respect. Now, another treatment for myeloproliferative neoplasms, and in particular polycythemia vera, is the use of pegylated interferon. So pegylated interferon, or otherwise known as Pegasus, is slow release interferon. So the advantage of that is you only have to do 1 injection a week. And I must say this medication is given by injection, and it's given subcutaneously, just like a diabetic gives insulin. But for people that can't take hydroxyurea, Pharmac have now funded this drug in New Zealand. As you can see, this drug was originally developed for hepatitis C. But hepatitis C is now, thankfully, a disease of the past. People with hepatitis C can have their hepatitis eradicated by a 12-week block of treatment. So this drug, Pegasus, is no longer needed for hepatitis C, and it's been brought across to treat myeloproliferative neoplasms, and in particular PRV. But the reason why I mention that is because it comes in a very awkward, large dose. And you can see the dose on the side of the box, 180 micrograms per half a mil in the syringe. And we, when we start this off, only need a quarter of that amount. So we often start people off at only 45 micrograms, so a quarter of the half a mil, so a very small dose. And we start them off on a small dose once a week and then gradually increase the dose, again, according to side effects and in terms of response. Now, side effects with interferon are unfortunately quite common, and people can get fatigue, headache, mild fever, muscle wasting, and problems with liver function as well. So again, a drug we just need to use carefully, but it can be very effective. And you know, and certainly if we have a patient with a myeloproliferative neoplasm who gets pregnant, where hydroxyurea should not be used, then we obviously need to switch them across smartly onto treatment with interferon. One of the interesting things about the treatment with interferon is that there is some evidence that it reduces the JAK2 allele burden. So what does that mean? Well, that means if we look at the bone marrow cells and we look at the percentage of cells in the bone marrow that have got the JAK2 mutation, usually in somebody with polycythemia vera who's JAK2 positive, that'll be 100% of cells. But there are some people that when they go on to interferon for treatment of polycythemia vera, the amount of cells that are JAK2 positive starts to diminish. And so the percentage of JAK2 positive cells in the bone marrow starts to decline. And that's what we call by a reduction in the allele burden. And people that get a significant reduction in the allele burden with alpha interferon, you know, the question is, well, does that mean a better prognosis long term? Short answer is we don't know that yet. I mean, there are studies going on worldwide to see whether interferon might give better long-term results compared to treatment with hydroxyurea, but we don't know that answer yet, and we certainly can't say that it does at this stage. So hydroxyurea is still the preferred treatment, but as I've said, for people that can't tolerate hydroxyurea for whatever reason, pegylated interferon is an option and is now funded by Pharmac. But it does have to be given by injection, and it does have significant side effects. Moving on now to a relatively new drug called ruxolitinib. So ruxolitinib is funded in New Zealand for people with myelofibrosis. What is ruxolitinib? Well, it's a medication that is a JAK2 inhibitor. So it targets the abnormal mutated JAK2 gene and acts to try and suppress that or switch it off a bit. All right, so ruxolitinib is quite an effective treatment for patients with myelofibrosis, but it doesn't cure the disease and it doesn't necessarily prolong life. But having said that, there is growing evidence that ruxolitinib may be a slightly better treatment for people with myelofibrosis compared to hydroxyurea or hydroxycarbamide. What can ruxolitinib do? Well, it can certainly help control a swollen spleen. So people that have an enlarged spleen due to their myelofibrosis, the spleen will often stabilize or even reduce in size if people are treated with ruxolitinib. And for people that have weight loss and drenching sweats from their myelofibrosis, ruxolitinib is very effective at switching off those symptoms and allowing people to put on weight and get into better condition. So ruxolitinib, quite a helpful treatment for people with myelofibrosis. And, you know, although it can't cure the disorder, although it can't switch it off completely, it does seem to be slightly superior to hydroxyurea. One of the things that ruxolitinib unfortunately can do, particularly when it's first started, is it can make people more anemic, and it can make people drop their platelets slightly. So we do have to use it carefully. We do have to start it at a lowest dose, particularly if people are already anemic and already have low platelets. But we do try and increase the dose. Certainly, we want people to have at least 10 milligrams a day, and ideally more than that, to try and control their myelofibrosis. So if people have moderately or advanced myelofibrosis in New Zealand, Pharmac have funded ruxolitinib, which can be used as first-line treatment as a preferable treatment for people with myelofibrosis. And it's particularly a helpful treatment for getting people into better condition, especially if they're youngish and are being considered for bone marrow transplant. So just to follow on with the ruxolitinib, we start at 10 milligrams twice a day and increase slowly. Side effects, headache, dizziness, and unsteadiness, as I've listed there. And it can be used for polycythemia vera, but it is very, very expensive. So it's not funded for polycythemia vera, and you really would have to be a very wealthy person to be using ruxolitinib for treatment of polycythemia vera. But if you have myelofibrosis, yes, it's quite an effective drug. Ruxolitinib, interestingly, is a JAK2 inhibitor, does have some other benefits, and it is now used for the treatment of graft versus host disease after people have bone marrow transplant. So it's quite an interesting drug, and certainly is being used outside of just the myeloproliferative space. One of the things I often get asked about is the evolution of myeloproliferative neoplasms, because people often say, all right, I've got polycythemia, and yes, I can have it controlled, but what's going to happen to me in 5 years or 10 years or 20 years time? Am I still going to be okay? And the reality is we can't answer that for any individual person with any certainty, really, because myeloproliferative disorders can evolve, and they can particularly evolve to develop myelofibrosis, where the overproduction of red cells or platelets changes over time as scar tissue starts to become laid down in the bone marrow. And so the bone marrow function moves from a state of overproduction of blood cells to being overrun with scar tissue, and then getting to a point of underproduction of blood cells. So that change or evolution towards myelofibrosis is often associated with increasing swelling of the spleen. So often people with polycythemia vera or essential thrombocythemia, when they go to our hematology clinics for checkups, we will almost always feel their tummy and check to see whether their spleen is starting to swell. Because if the spleen does start to enlarge, or particularly enlarge significantly, then we do get concerned that they may be starting to move towards myelofibrosis. We also look at their blood test, and if we see immature precursors starting to appear, then we do get concerned. And if that starts to happen, we will often say it's time to have a bone marrow test and see whether myelofibrosis is really developing. And if that's the case, it may well prompt a change in treatment. And the other thing that people do get quite worried about is if they have a myeloproliferative neoplasm, am I going to get acute leukemia? Well, the short answer is probably not. And the vast majority of people with myeloproliferative neoplasms don't end up having acute leukemia. But having said that, if you do have a myeloproliferative neoplasm, you do have an increased risk of developing acute leukemia compared to a person who doesn't. So yes, this is a complication that can occur, but thankfully it's a very small minority of people. In terms of who is most likely to develop acute leukemia, well, if you present with myelofibrosis, there is a higher risk, as opposed to people that have polycythemia vera or essential thrombocythemia. And if when you have your bone marrow test done for myelofibrosis, we test your chromosomes or cytogenetics, and we find there's abnormalities of those chromosomes, then you are at higher risk of developing acute leukemia. And those are the people that we worry about, that they might start to move towards leukemia. And if that's the case and you're a younger patient, then we'll certainly look at the option of you having a bone marrow transplant, because we want to do a transplant before the transformation to acute leukemia occurs. So that leads me on to talk briefly about bone marrow transplant. So bone marrow transplant is really the only curative treatment for people with myeloproliferative disorders. It is a risky procedure, so it's something we only really undertake in people that have myelofibrosis. And we're particularly looking at people with moderately high risk myelofibrosis. So we do have a scoring system where we score people with myelofibrosis as to whether they're low, intermediate 1, intermediate 2, or high. And certainly if people have intermediate 2 or high scores, then we will certainly be looking at them to see whether bone marrow transplant is right for them. Age is one of the things that we particularly look at, and we usually only consider bone marrow transplantation in New Zealand for people that are under 65. And you need to be otherwise well. So we don't want major problems with other organ systems. We want people to have good heart, good lungs, good liver, and so on. And as I've mentioned, we want to try and do the stem cell transplant before the disease is too advanced, and certainly before it starts to move towards leukemia. So as I mentioned there, preferably done before the spleen is too big and before people get too iron loaded. And why might somebody with myelofibrosis get iron loaded? Because if they're given lots of blood transfusions, every time you get blood, you get iron. So we want to try and avoid people getting increased iron stores, because that does compromise their transplant outcome. To have a successful bone marrow transplant, you need to have a matched, healthy donor. And matched, I mean matched with their body type or tissue type. So if somebody's being considered for a bone marrow transplant, we do what's called tissue type testing and see what body type they have. And then we look at their siblings, brothers or sisters, and see whether they have the same body type or tissue type. And if they do, that's good, they're a match. But if we don't find a matching sibling, then we may go to the bone marrow donor registers. And in that case, we search for what we call a matched unrelated donor, or a MUD donor. And a MUD donor is somebody that is unrelated, but is matched in terms of having the same tissue type or body type. And if we still can't find a MUD donor, then we occasionally look at other family members to see whether we can find a half-match donor. And that's what we call a haploidentical donor. And some people can have a haploidentical donor transplant and it still be successful for them. The complication rate is higher with a haploidentical donor. The best donor, if you're going to have a bone marrow transplant, is still a fully matching sibling, brother or sister. Bone marrow transplant, as I've said, is not without risk, and the major complications I've put on the slide there. So graft failure, where the graft doesn't take, can be a concern. Infection, particularly whilst you're waiting for the graft to get established within the bone marrow. Graft versus host disease, and that's where the foreign bone marrow cells start attacking the patient's body because they recognize them as foreign. You can get relapse of the myelofibrosis, which obviously is very disappointing. And unfortunately, people going through transplant can die from the procedure. And the death rate from bone marrow transplant in myelofibrosis is in the order of about 20%. So it's not insignificant, So if you put up for a bone marrow transplant, there is unfortunately, a 1 in 5 chance you may not come out the other side for whatever reason. So it's not something we entertain lightly, and it's something that needs to be carefully considered and carefully discussed with your hematologist. The upside of having a bone marrow transplant, of course, is it is curative. And a successful bone marrow transplant can really, be a godsend for that person, and can really mean that the person, once they're over the complications and off much of the immunosuppressive therapy, they can really resume normal life and have an excellent long-term prognosis. So what about other problems with myeloproliferative disorders? Well, itch, or what we call in medicine pruritus, can be a bother, and it particularly occurs after showering or having a bath. So we say to patients, if itch is a problem, don't have a bath, always have a shower, always have a low flow shower that's not pounding on your back too much, and always have it tepid, so it's lukewarm water, not hot. And if despite those precautions, itch is still a bother, then we can treat with antihistamines and moisturizers for the skin. But to be honest, there are some patients that despite all of that, still have very disabling itch that can really bother them. So not an easy problem to solve, but certainly there are some common sense measures that can make it more manageable. Erythromelalgia is an uncommon complication of polycythemia vera. But when it occurs with burning pain or redness in the hands and feet, particularly affecting the toes, it can be treated very effectively with low-dose aspirin. So anybody that's diagnosed with polycythemia vera who happens to have this complication, getting them straight onto aspirin is often very effective and will often make their toes and feet much more comfortable. Visual disturbance, well, as I've mentioned, polycythemia vera with sludgy, viscous blood can cause visual disturbance because the blood flow through the small blood vessels in the retina at the back of the eye can be very sludgy. So if people do have any visual symptoms, get to an optometrist, get checked out. And certainly if people have a sudden visual loss, then they need to be seen urgently by an eye specialist. So very important that we always ask about vision. Headaches can often be a problem with polycythemia vera. And my message to people that have recurrent headaches is keep hydrated, because that does reduce the viscosity of the blood and improve blood flow around the brain. And often people with polycythemia vera will know when they need to have another venesection because they start getting headaches back. And headaches can be a sign that the hematocrit is getting high again, and it's time to have some more blood taken off. Iron deficiency. So iron deficiency can occur if you are having regular venesections. So if you're having pints of blood taken off fairly frequently to control your polycythemia vera, then not only are you having red cells taken away, but every red cell contains iron. And so in time, you will become iron deficient. And iron deficiency caused by frequent venesections can make people feel irritable, it can reduce their concentration span, and it can make people very frustrated and short-tempered. So if that occurs, we sometimes look at very gentle iron replacement therapy, perhaps 1 or 2 iron tablets a week, just to try and keep the iron stores up at a manageable level. We don't want people to be filled up with lots of iron because otherwise their polycythemia will take off and need very vigorous management. So finally, just to mention about the uncommon myeloproliferative disorders. Hypereosinophilia, where there's an overgrowth of eosinophil white blood cells, is an important diagnosis to make. And there are some certain gene rearrangements that are associated with subgroups of hypereosinophilia. And some of those gene rearrangements do respond to treatment with imatinib, imatinib being a drug that we use for chronic myeloid leukemia. So very important if you have a hypereosinophilic syndrome that you have the appropriate gene testing done and they see whether you might be somebody that responds to imatinib. Chronic eosinophilic leukemia that doesn't have the specific mutations can be treated with hydroxyurea. And there is another drug called mepolizumab, and mepolizumab stops eosinophil production and is very effective at reducing the eosinophil count and prevents tissue damage from high eosinophil levels. So mepolizumab can be used, although it's currently not funded. We have to apply for special funding for it. And then there's a disorder called systemic mastocytosis, which is an overgrowth of mast cells. And mast cells are very rich in histamine. And mast cells, often people present with mastocytosis with an itchy rash. And the special test we always do is a tryptase level. And if the tryptase level is high, then we look for that mutation of D816V I put on the slide. In people with systemic mastocytosis, where there's mast cell overgrowth involving lots of tissues within their body, there is treatment for, and I've listed some drugs on the slide there. And just to let people know, cladribine is a gentle chemotherapy, can be helpful. Midostaurin, not funded by Pharmac yet, but can be advantageous. And there is a new drug called avapritinib, just been approved by the FDA earlier this year, and that seems to be very effective, and that there is currently a compassionate access program open for that drug. So if you are a patient that has systemic mastocytosis and you're struggling with it, then do tell your hematologist to contact me, because we may be able to get this drug avapritinib for you. So there are a group of overlap syndromes with the myelodysplastic syndromes, but I'm not going to embark on that, because treatment for those overlap syndromes is very much like the treatment of myelodysplasia, and it does include bone marrow transplant, but we don't have time to go into that. So that concludes my presentation. Just to finish with a slide of Waikato Hospital, although we were attacked by a vicious cyber attack earlier in the year, we are a big catchment, of over 800,000 people for our acute leukemia and autologous transplant program, a busy hematology department, and we're always trying to do our best for our patients with myeloproliferative disorders. So I will finish there and stop sharing the screen and hand back to question time.
Thank you so much, Humphrey. It's incredibly informative presentation. We've just got a couple of questions coming through. The first is, why do you refer to it as a disorder rather than a neoplasm?
Well, that's because I'm an old-fashioned hematologist. So when I trained, they were always called myeloproliferative disorders. But in recent years, and certainly following the discovery of the JAK2 mutation in 2005, we now know that they are clonal, and in that sense, they are neoplastic. So they are in a strict sense, a form of cancer, but a very indolent form of cancer and a very slow growing and slow moving form of cancer. But they are just a group of neoplasms that are more common in older age, and and like most cancers, people develop them for unknown reasons, and why that JAK2 mutation occurs, we still don't know. We still don't know what flicks the switch and causes the bone marrow overdrive problem.
Thank you. Our next question. Why do you not include PMF when talking about HU and Pegasus? These are the treatments I've been on for 11 years, Pegasus for the last 2. Okay,
well, I should have mentioned the fact that hydroxyurea and Pegasus can be used for primary myelofibrosis. Yes, they are quite effective. Hydroxyurea can certainly help controlling spleen size to some extent, and Pegasus can certainly suppress the disease to some extent as well. But I think internationally there is quite a move towards using JAK2 inhibitors if people can tolerate them. So certainly if people have moderate or advanced primary myelofibrosis, then I think JAK2 inhibitors are now becoming the preferred treatment of choice.
Thank you. And looks like this might be the last question. Does the evolving of PRV and ET to MF happen slowly, or can it be quick?
Slowly for most people, but occasionally it can be quick. When I say slowly, usually over a year or 2, where we see the spleen gradually getting larger, we see the blood picture and the blood test slowly changing, and then we do the bone marrow, and there we are, we see the myelofibrosis. But sometimes it can happen over a few months. And if that's the case, then we do worry that, that myelofibrosis may be associated with abnormal chromosomes or cytogenetics, and it may have other abnormal genes that are driving the change and driving the change quite rapidly. And certainly a rapid transformation to myelofibrosis, we do worry that those patients may go on to get acute leukemia.
And actually, we've just had another question come through, so we'll make this the last one. Just a question around transplant age of being 65 or under. Is that a hard and fast rule, or is there some flexibility to that?
There's certainly a lot of flexibility around it. 65 is just a rule of thumb, really. And I, look, if people are otherwise well and have good heart and lungs and, no history of other cancers and so on, I'll certainly refer people through for transplant, even though they may be 67, 68. So it's not hard and fast, but the complications of bone marrow transplant certainly do increase with age. And certainly the older you are, the higher the risk of graft versus host disease and so on. So you do reach a point where, the risk of doing the transplant is very high, and, the risk does outweigh the potential benefit. So 65 is a rule of thumb, but it's not hard and fast, and most transplant centres at Auckland, Wellington and Christchurch would accept patients older than 65, and, even up to 70 in some very good fit patients. But I think, transplant, as I've mentioned, is not without risk. And if you're an older person, you certainly need to go into it with your eyes open and your family well informed, in regard to taking that decision.
Thank you. Well, I think that just about takes us to time. Thank you everyone for joining us for this session, and a huge thank you to you, Humphrey, for sharing your time and knowledge with us this morning. It's been incredibly beneficial, and thank you again very much.